Well, we're going to switch gears a little bit in terms of the thinking in Tetralogy of Fallot. And you've heard about the anatomy and how we define it. But really, if you look over the decades, we're discovering that patients over the decades, not if we look over the decades, but as patients get older, we thought we had repaired this lesion, but really patients have a lot of problems. And they have problems in their exercise tolerance, in their symptoms, as well as ventricular and atrial arrhythmias. And there are many potential problems or reasons why Tetralogy of Fallot patients can have decreased function that lead to these issues. Some of this might be related to right ventricular hypertrophy. There might be intrinsic myocardial abnormalities. Studies have shown fibrosis. We've heard about coronary abnormalities. And together, these can lead to contractile abnormalities in the ability of the muscle to generate pressure. You have a large VSD patch. You have right bundle branch block and abnormalities in the timing of contraction, which I'll speak about, leading to dyssynchrony. These can affect pump efficiency and again, probably will relate to contractile abnormalities as well. And in addition, if you do have residual outflow tract obstruction or small branch pulmonary arteries that haven't grown as well, you also have increased afterload. And we've heard that about pulmonary regurgitation, tricuspid regurgitation, residual shunts in the form of ASD and VSD, all of these increase preload and contribute to problems. So one of the ways that we can look at function, and that has been studied, this played 3 seconds ago. No, it's going over the lecture right here, but it doesn't now. Anyway, if you take color tissue Doppler that we talked about yesterday, and then you place a region of interest on the right ventricular free wall over here, you get a systolic velocity, an early diastolic and a late diastolic. We saw that yesterday many times, so getting used to these images. And if you look at the systolic velocities of this right ventricular free wall, it's around 4 or 5 centimeters per second. That is significantly reduced. And this is a tetralogy patient who was thought to have good function. I wanted to play you the clip. I don't know why it isn't playing right now. So if you look on aggregate work from Michael Vogel, you can indeed see that systolic velocities and diastolic velocities, by the way, are reduced in Tetralogy of Fallot. So we know that there's a problem with their cardiac displacement with their velocities. Some people have gone a step further, and we talked yesterday about the myocardial performance index, that isovolumic contraction and relaxation periods over the ejection time. Some people have showed that tissue velocities are actually helpful in showing that patients with Tetralogy of Fallot have increased myocardial performance index, meaning worse function, whereas you may not be able to show that easily, at least on the right ventricle, using normal blood flow. We also, I showed you this slide, we talked about isovolumic acceleration on tissue velocities, this initial systolic deflection during the QRS complex, during isovolumic contraction, that is relatively load independent. And indeed, in Tetralogy of Fallot, the IVA, the isovolumic acceleration, is quite decreased. This would suggest that it's not just the motion that's decreased, but as we said, it's a relatively good index of contractility, then contractility itself is decreased. And because it's relatively independent of loading conditions, that's what I meant. There might be intrinsic myocardial abnormalities here. It's not just related to the loading, but something is causing the muscle to have reduced contractility, be it the fibrosis or maybe structural problems. And I'll come back to this later, but I want to show this now with IVA. You can see, though, that as pulmonary regurgitation becomes more severe, and these are group averages, so there's obviously overlap, but you can see that in general, your isovolumic acceleration decreases. So the pulmonary regurgitation certainly has some role over here. Now that's tissue velocities, but we also talked yesterday about strain, about the shortening and lengthening of the tissue, and we said we can measure that in different ways, either using color tissue Doppler and using differential velocities, or we can use speckle tracking techniques following these speckles in the myocardium, and then assessing how the tissue deforms over time. And indeed, as I showed you in that previous picture from our lab, and this is an article from a few years ago from Shelby Cutty and Peter Frommelt, showing that you can get right ventricular strain from these techniques. And so if you look at strain, and actually this is from color tissue Doppler from Frank Wiedemann, who's now in Germany, was in Leuven at the time and has done wonderful work in ventricular function. So if you're looking for someone whose work to look up, I talked about Benedict Askins yesterday, and Frank Wiedemann has also done great work. You can see that there are decreased velocities in the right ventricular free wall, in the septum, and in the left ventricular free wall, and I'll get back to this. Strain rate is decreased, strain is decreased. Remember this, we have two ventricles in the heart, and we tend just to talk about the right ventricle in Tetralogy of Fallot, or the left ventricle in other diseases. Both ventricles are involved in a disease, and they both sit in the same space, if you will. Now, if you look at right ventricular strain in Tetralogy of Fallot, I showed you it was decreased. Some groups, and this is Tim Kimball's group from Cincinnati, have shown or have found that the septal deformation isn't as reduced. I'm just bringing this up because you'll see that there's a lot of different findings in Tetralogy of Fallot. Despite this being a very, very well-investigated region, we still are trying to understand what happens. So this group attributed the relatively normal septal deformation as a compensatory mechanism, if you will, for the decreased right ventricular strain. I have different thoughts. I'll show you other data, but there are different results out there. But what may be useful in strain imaging, because we can acquire it very easily during the echocardiogram, analysis is relatively simple to perform, that if you have sufficient reliability, you can follow the patient over time, because I told you that this is a progressive condition in terms of the ventricular dysfunction. So if you look why it may be good, if you just look at RVEF, and this I think is by MRI, you can see that over a follow-up period of about 4 to 5 years, the ejection fraction didn't change that much. And it didn't change that much because both the end systolic and end diastolic volumes increased. But if you look at the strain, either globally in the right ventricle or just in the free wall, you had quite a significant decrease in strain. So that might be a good way of following these patients over time. Now, fine, you sit there and you say, fine, he's told me that strain is decreased, but if you think why strain should be decreased in Tetralogy of Fallot, it's not, the answer isn't that straightforward. So why is it reduced after repair? Well, one of the reasons that it may actually be reduced if you have residual stenosis is an increased afterload. This is again work from Frank Silverman, but this is pulmonary stenosis, but just as a correlate, if you have increased afterload, and a long-term problem in many patients are small branch pulmonary arteries that don't grow as well over life, you're going to get decreased deformation of the right ventricular free wall. But really, most of the emphasis recently in Tetralogy of Fallot in the long-term function has focused on pulmonary regurgitation. In the early years, people thought that this was less of a problem and valves weren't preserved. And as both Dr. Sanders and Silverman told you, there's a lot of effort that's made to preserve pulmonary valves because of the emphasis on pulmonary regurgitation. So if you look at work that was done when Andrew Reddington was still in London, you can see that both as you increase your pulmonary regurgitation, your IVA decreases, your right ventricular strain decreases, and your strain rate generally decrease. So there seems to be some association with PR. But regardless of the PR, whether it's mild, moderate, or severe, if you look at QRS duration, you can see that as your QRS prolongs, your strain rate becomes less negative. If you remember, we talked about longitudinal strain. More strain is more negative because it's shortening. So a less negative number means less deformation, or in this case, strain rate. So as you widen your QRS duration, you're also decreasing your strain rate. Now, QRS duration is one surrogate for right ventricular size, but then you'd have to think it would be related to the PR, and we see that it is related to the PR, but we'll get back to QRS duration later, but this is an interesting finding. And QRS duration is something we follow routinely in the clinic, and you know from Michael Gatsoulis's work that a QRS duration that's above 180 is a risk factor for ventricular arrhythmia and sudden death. So these mechanisms start to come together. Now, I said to you that QRS duration is important. I talked about pulmonary regurgitation and ventricular enlargement. But if you look at the scatter plots from that same article, you can see that it doesn't explain everything. And in fact, the correlation over here is quite weak. So we're studying these things and we're bringing them up time and time again, but we haven't explained everything. One of the things I told you yesterday, and I'll come back to that in the next talk, when we talk about truncus and I'll talk about aortic insufficiency, is should we be correcting deformation for loading? Because as these ventricles enlarged, I showed you yesterday, that strain will naturally go down because you need less deformation to produce a stroke volume. So maybe it's related to that. And indeed, again, work from Andrew Gregalescu, who kindly lent me this data, hasn't been published yet. If you increase your end diastolic volume, in general, you see a decrease in deformation. But the normal people sit over here, and the tetralogy patients in lighter blue sit up there. So now let's correct that for volume, if you will. And here Andrea has corrected it for pulmonary regurgitant volume. You see the normals sit here on the 0 because they don't have pulmonary regurgitation. But the tetralogy patients, we've corrected strain for end diastolic volume. As they increase their regurgitant volume, their strain generally decreases. So even though you've corrected for the volume, the pulmonary regurgitation still seems to have an effect beyond just increasing right ventricular size. If you look at this, I showed you the slide for ASD patients yesterday. Here is the right ventricular output. Here is strain corrected for right ventricular size. Here are the normal patients in orange. Sorry, this works intermittently in orange. Here are the ASD patients, which I showed you yesterday in green. They have relatively normal deformation corrected. But the tetralogy patients in blue have decreased deformation. So regardless if you're correcting this for pulmonary regurgitation, for ventricular size, you're still getting low strain. This tells me that these patients have intrinsic abnormalities of their contractile function beyond the simple loading. It's true we haven't corrected for afterload here, but most of these patients, at least frank pulmonary stenosis, didn't have a residual right ventricular outflow tract stenosis. And I'm going to, this is the same. So one of the things that has gained a lot of attention now, if we're talking about pulmonary regurgitation and pulmonary stenosis as possible factors in the pathophysiology of dysfunction here, is if you find this to go and implant a pulmonary valve. Now, the indications for pulmonary valve replacement are controversial. We can discuss them. If patients are symptomatic, people will replace the pulmonary valve. If patients are asymptomatic, you can have whole symposia on when to do that. But generally, if you have a very dilated right ventricle or an increasing right ventricular volume of different dimensions, people will replace the pulmonary valve. So how does this affect function? Because ultimately, that's what you're trying to do. Well, if you look at pressure loading as an indication, so you have stenosis, you have right ventricular outflow tract obstruction. If you look at that as the indication for pulmonary valve replacement, then you get, I would say, very modest increases in function. By the way, you do get an increase in exercise capabilities, and it correlates quite, wouldn't say well, but moderately with isovolumic acceleration. But if you look here, here's before pulmonary valve implantation. Immediately after 1 month and 3 month follow-up, you can see that there are very mild changes in systolic velocities and perhaps in isovolumic acceleration. But what the London group has nicely shown, and this is work from Philip Lutz and Andrew Taylor from the MRI group at Great Ormond Street, is that when you replace the pulmonary valve, you change the dynamics between the right and left ventricle, which are mediated in part at least through the ventricular septum, And if you look at strain curves at this patient before with right ventricular outflow tract obstruction, before pulmonary valve replacement and after pulmonary valve replacement, you can see how the strain curves are much more synchronous. The ventricle contracts and relaxes at the same time, and the filling of the LV improves. So that's perhaps a mechanism of how exercise intolerance improves and how this works. But most of our patients, or many of our patients, just have very big, baggy right ventricles, as Karen will show you soon. And if you look at these patients and you replace the pulmonary valve, the Zurich group has shown actually that strain doesn't improve after you replace the pulmonary valve. Here is the healthy controls over here. Here is before the procedure. Immediately after the procedure, strain goes down. There's some recovery. It certainly doesn't get to control values, and it doesn't even get to preoperative values. That's surgical correction of the pulmonary valve. So you could say it's related to the bypass and to other effects, etc. We looked at this when the transpulmonary valve catheter intervention first came out, well, not first came out, but came out a few years ago, and we actually found improvements immediately after the procedure in a small group of 10 patients in both the septal and right ventricular function. But I can tell you that this data doesn't stand with most other data that have actually shown in much larger groups and looking further on, 1 and 3 months after pulmonary valve replacement, that right ventricular strain, and here these are velocities, it's true for strain as well, and IVA, generally do not go back, do not recover to pre-procedure values. So if you're taking a patient with decreased right ventricular function, decreased deformation, a big RV with pulmonary regurgitation, and you're putting in a pulmonary valve to preserve their right ventricular contractile function or deformation, you're not going to get good results. So whatever improves the patient's symptoms, and they do improve symptomatically, it's probably just related more to the effective forward flow and left ventricular filling than actual right ventricular deformation. And this is something we need to watch because we're doing a lot of procedures. Our indications are a little bit grey, I would say, or undefined or unresolved, and we don't know exactly what the implications are. We haven't seen major improvements. Here's a patient from our lab after pulmonary valve regurgitation where the strain curves look almost exactly the same and they're reduced, and this is a longer term follow-up. Now, I told you that there are 2 ventricles in the heart, and never forget the other ventricle, even if the emphasis is on the right ventricle. And I showed you from Frank Wiedemann's study in velocities, and I'll show you again that wherever you look in the left ventricle, or however you look at the left ventricle, whether it's by motion, deformation, or percent deformation, strain rate, and strain, the left ventricle has decreased strain. We've looked at this now in a very detailed way, and in every segment, if you look at radial strain, and the same is true of circumferential strain, you get quite significant decreases in left ventricular deformation. It wasn't so true for longitudinal deformation, and we've mapped this in quite a detailed way, and looking at these factors and how they interact in terms of pulmonary regurgitation and right ventricular end diastolic volume by MRI, and there are associations. Now, I want to talk about something that I won't talk about again, and we haven't talked about up to now, but may be important in Tetralogy of Fallot, and that's about the timing of contraction. The ventricle can function well or abnormally, but if the different walls and if the right and left ventricle don't contract nearly simultaneously, your output or your pump function is going to have reduced efficiency. And so in heart failure in adults, many thousands of patients have received cardiac resynchronization therapy to resynchronize the contraction when you have decreased function and a left bundle branch block. So what about Tetralogy of Fallot, where we have decreased function, we have a right bundle branch block, and we have arrhythmias? How does this interact? So you can see, first of all, that if you have a right ventricular delay in the time of contraction, and here's an example how you might measure dyssynchrony by looking at strain curves and measuring the time to peak strain in each, you can see, as opposed to what I showed you before, that the different parts of the right ventricle do not contract at the same time. If you look at QRS duration, and you take that as a surrogate for electrical dyssynchrony, so you're not activating all the ventricular parts at the same time, you can see that in general, strain decreases with an increase in QRS duration. I showed you that before. So your electrical abnormalities translating now into mechanical abnormalities. So what about the mechanical abnormalities? Well, Candace Silverside's group over in Toronto General Hospital, which is across the street from where I worked, have looked at this in adults with Tetralogy of Fallot, and again shown the same thing. The more you widen your QRS duration, the worse your dyssynchrony comes, your delay measured by strain, and the worse your curves look. Other groups, and this is the German group some years ago, showed that left ventricular function decreases when you have mechanical dyssynchrony, and they measured this with the myocardial performance index, and they also showed that patients were more symptomatic in this situation. But it's been very difficult to prove a direct relationship. I haven't found a direct relationship just with these dyssynchrony measures. And in the same group from Toronto General, you get scatter plots like this, that the peak to time delay, so that measure of abnormal timing of motion and ejection fraction is actually, there's no relationship. But other groups have shown that there is dyssynchrony, and this is Michael Vogel's work, and that if you have a delay, your outflow tract is quite abnormal. So I'm just going to skip this. This is my last slide. I've got a sign from the boss there to end. And just to say that I've been saying all along that abnormalities may not only happen at rest, but when we provoke patients in terms of exercise and the heart needs to do more and contract, that's when you discover abnormalities. And I, together with Lucy Roche, have shown that if you exercise patients on a bicycle and you echo them, whereas normal controls will actually decrease their or increase their synchrony, they'll contract more synchronously in the black. Tetralogy of Fallot patients increase their dyssynchrony. They have less synchronous contraction during exercise, both in the right and the left ventricle. So I'm going to end there. Thank you.